Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup Compliance Webinar Series. Today's topic is 2026 Medicare Physician Fee Schedule Proposed Rule, Part 2. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional comments. Any questions posed during the webinar will be responded to via email after the webinar. We've posted a PDF copy of the presentation slides for your reference in the Resources pane. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross and Valerie Rock.
Thank you, Jennifer. Good morning, everyone. Thank you for joining us for part 2 of our webinar series on the Medicare Physician Fee Schedule. I am Martie Ross. I am thrilled to be joined today by Valerie Rock, who leads our firm's revenue integrity team and knows the down and dirty of the Medicare Physician Fee Schedule like no one I've ever seen before. Before we get to content, we of course must remind you again that comments to the rule are due by September 12th. It is super duper easy to submit comments. You see here on the screen a shot of the Federal Register website where you can simply click a button where it says submit a public comment. That will bring up the screen that you see there on the right-hand side. And you just type in your comments, or you can actually attach a Word document as well. You'll see we're closing in quickly, about 30 days left to comment. There's already, this is as of Monday, there are 1,536 comments that have been submitted. Let's get it to a 4,000 if we possibly can. But anyway, for today, the second half of this series, we're going to focus on telehealth changes, global payment reforms, and skin substitutes, as well as new provisions relating to care management and prevention and wellness. A reminder, if you did not attend part 1 on July 30, it is available on demand on our website. And you can see there on the screen the topics we covered in that webinar. So without further ado, let's dive into telehealth changes. I'll get this started, but then turn it over to Valerie to get into the details. And I want to start with where we are today, as we are facing what we refer to as the telehealth cliff on September 30. And the reason we find ourselves staring down into that abyss is because Congress has yet to act on extending the waivers that first went into effect back in March of 2020 that expanded coverage for telehealth services significantly. And most importantly, it made those services available to individuals in their homes, regardless of whether they live in a rural or urban area. So where things stand today, it's better than it was in February of 2020, because back in the Consolidated Appropriations Act 2021, Congress did make permanent Medicare coverage for telehealth services furnished in the home, but limited that extension to telebehavioral health services, and provided that these services can be billed when furnished by physicians, practitioners, as well as rural health clinics and federally qualified health centers. However, when we get to October 1, if Congress has not acted, we will then be subject to a face-to-face visit requirement. So prior to initiating telebehavioral health services, the billing practitioner will need to have seen the individual face-to-face within the prior 6-month period. And then going forward, there'll be a requirement that there be a face-to-face visit once every 12 months before continuing on telebehavioral health services, although the regulations have permitted certain exceptions for that. Going forward then, also October 1st, in addition to those new requirements on new restrictions on telebehavioral health services, for medical telehealth services, our coverage will go back to the requirement that the beneficiary be physically present at a facility located in a rural area at the time the service is delivered for there to be coverage. Additionally, physical therapists, occupational therapists, speech language pathologists who had previously been able to bill for certain telehealth services no longer will be able to bill for those services. And so that's where we stand, absent some congressional action either to make permanent that degree of coverage or at least to extend those flexibilities for a period of time. By regulation, we have some adjustments by regulation through the end of this year, not October 1st, but the end of this year. Rural health clinics, federally qualified health centers can continue to be distant site providers for medical telehealth services, and they bill for those services under G 2025 as opposed to the specific code for the service furnished. Through the end of this federal fiscal year, September 30th, those medical telehealth services that CMS previously identified as covered as using audio only, those will continue to be covered with the exception of the specific code you see there noted on the screen. And then going forward on a permanent basis, telehealth services will be covered when furnished audio only, if you see the three specifications that are listed on the slides. That's a change that were made in the 2025 Medicare physician fee schedule. So that's today. I'm going to turn this over now to Valerie to talk about what CMS is proposing in the 26 fee schedule.
So while CMS doesn't have the authority to, address the 1834M changes, they do have some authority to make some changes, right? So this is what they're doing, right? So we're going to look and see what are they doing with telehealth that they can do. And as of right now, they're saying, okay, we're going to take the list of telehealth services and we're not going to have them be provisional and permanent, as two different types. We're just going to say if they're approved, they're permanent. And they have the authority to remove them if they want to. So they've taken the criteria for getting into this telehealth list from 5 criteria to 3. And so what they're asking is the service separately payable when furnished in person under the physician fee schedule, which means is it separately payable by the physician fee schedule? Is the service subject to 1834M, which is the telehealth provision? Is it truly a telehealth service? And then when you look at the descriptor as the HCPCS or CPT code descriptor, what are all the criteria within that descriptor, and do all of them meet the ability to be performed via interactive telecommunication? So if any of those are not met, then they cannot or they will not approve them. Now, of course, this is proposed to remove this, but most likely to move forward because these additional steps 4 and 5 were high hurdles to meet. And a lot of people had difficulty pulling together the data and the information, especially if they were new technology, and to provide that or pull that into telehealth services. Remember that you can submit your recommendations for telehealth services by February 10th of 2026 for consideration for the 2027 list. So when we look at what has been included or what is proposed to be included in the telehealth list, it's including the 90849 for multiple family group psychotherapy, G0473 for group behavioral counseling, G0545 for the infectious disease inherent complexity code, 92622 and 623 for the auditory osseointegrated sound processor programming. And so all of those are likely to, be added to this list. Whereas if we look at the services that are not being added, you'll see the reference to the issues of the 3 codes or the 3 questions that are supposed to be the hurdle that we have to get over. So the dialysis codes are not representing something that can be done in or remotely in total, right? So they're saying we don't see how this meets the criteria. Then the INR monitoring codes is a technical code, and therefore they're not seeing how that meets the criteria. And then the telehealth, so the AMA telemedicine E&M codes that were added last year by CPT are not payable under the physician fee schedule at this point. We bill under the R99,000 codes for that. So because these are not payable by the physician fee schedule, they're also not being included in this list. So they have to get over those 3 hurdles in order to meet the criteria. So when you're submitting your codes for inclusion, make sure you're meeting those hurdles because they will be immediately dismissed if not. We're going to talk about later how the SDOH code is being deleted because it's basically considered a part of other services. Now, one thing that they've adopted, that has come out of COVID is as they started increasing this or removing kind of limitations regarding the frequency limitations for subsequent inpatient visits, subsequent nursing facility visits, and critical care consults, that they've found that as of today, the volume of those services is fairly low that are being performed via telehealth. And there's an overwhelming adoption to this idea of removing this frequency limitation. So they're saying, okay, we'll do it. We'll remove the frequency limitation so that there's no limit. We don't anticipate any concerns regarding compliance with that. So you can take advantage of that when needed, right? So there may be some certain circumstances when that's appropriate. Virtual direct supervision is continuing to expand as well. And this is pretty exciting because, the ability to be able to provide the direct supervision is going to increase access to care where appropriate. Now, they want to make sure they're still limiting this where needed, but the way that they're doing this is to effectively revise the definition of direct supervision to include the description of immediate availability to also be defined as including the audiovisual real-time communication. Audio only is excluded. So immediate availability will mean, like within the suite or also via audiovisual real-time communication. They're excluding the global surgeries that have a 10 and 90-day global period. Of course, those are higher complexity and there's safety considerations there. So they want to include things like incident 2 services, diagnostic tests, pulmonary and cardiac rehab services, according to each of these provisions. So they're trying to capture a lot of services that would be included, but they are seeking your input regarding the 0-day global services. Now, the volume of 0-day global compared to 10 and 90 is fairly low, but they really are relying a good bit on physicians to make a clinical judgment on, whether something is appropriate or not as well. So they want to see, is it appropriate just to let these 0-day globals go open and that you can determine whether immediate availability means, within the suite and kind of an in-person availability or remote availability. So you can make that judgment call and include your comments related to that as well to make sure they're not missing anything. Teaching physician virtual supervision, however, is going to be more limited than that. So they are allowing through December 31, 2025, the ability to do this via virtual services for all locations. But in the future, as of January 1, the MSAs would be limited to in-person, both kind of supervision of telehealth and in-person visits. So there's an expectation that physicians would be involved in those key and critical portions of the visit. They are continuing to have a rural exception, however, for telehealth services. So if you have a 3-way visit where the physician, the resident, and the patient are in 3 different locations, you could continue to do that telehealth service in that manner, as long as the presence requirement is met through active real-time observation and participating in the service via audiovisual real-time communication technology and documenting to that effect as well. So making sure that you have that presence documented via that technology will be important also. FQHCs and RHCs, as Martie mentioned at the top, do have those additional provisions, that all of us have the mental health option for coverage via telehealth, but they also do. And these in-person requirements are through the end of 2025, but they plan to update their policy as of 2026 as the September 30 cliff is resolved and they see what Congress is going to do. So they'll start aligning with that policy at that point. But your non-behavioral health medical visits, as Martie mentioned, that G2025 will be able to continue to be billed through December 31, 2026. So effectively, FQHCs and RHCs are able to bill telehealth services through the end of 2026, unlike the ability that the limitations that we have in the MSA aspect. The CTBS services, your communication technology based services, they're looking to unbundle the G0071 to have you report the individual codes for that service. You'll see this kind of theme going through the APCM types of models. So they're kind of aligning with that service. Other things to note is that CMS is continuing to look at payment parity. They want to make sure that, that there is parity between the payment where appropriate, but are there services where payment parity would not be appropriate and they need to value these differently? They're looking at that and trying to make sure that they're valuing the services correctly. One big note and change that is impending based on this proposed rule is that there's no extension for those providers that provide telehealth out of their home. They would have to enroll their home location and bill based on their home location if they provide services out of their home as of 1/1/26. And the reason why this is important to note is because there's a lot of concern around safety because these addresses would be published. And if published, there's a concern that safety would be of the providers would be, compromised. So, comment if you are a provider that would be providing services out of your home, because we want to make sure that your voice is heard there. Martie's going to continue to discuss these other two bullets, so I'll go ahead and move on, but they are part of this kind of telehealth movement, if you will. So codes are continuing to be clarified and expanded there. So we're going to move on to global payment reforms. And I think this is an area where a lot of people kind of skip this. They've even asked for input over time on what does everybody think on how we need to value these global surgery components. You have the intra-service, the pre-service, and the post-service, especially these post-op visits. They believe that and have empirical data that we're overvaluing that service and perhaps even undervaluing the surgical component. And so they want to get this right. And because they were not able to bring this to a 0-day global back in 2015, they said, okay, well, we've got to determine how to value this. Well, now we're 10 years in and we have data based on the 99024 that has been reported over time based on the requirement for the 9 states that were and the certain practices that were required to report this. So they're using that data and saying, wait, this data doesn't match up to the physician time data. And so, how are we going to reconcile this? So they're asking for input. How do we get this to be more accurate? How do we revise the portion of the global surgery package to get the relative value unit attributed appropriately to that surgical procedure? What procedure shares should be based on the transfer of care modifier? And what are the current practice standards that are relevant to support the reasons for making that change? So last year, as a reminder, and it's important to note that modifier 54 is supposed to be utilized when there is a decision by the surgeon that he or she is not going to provide the post-op care. So you would use that modifier 54 to say, I'm only doing the surgical care and I'm relinquishing the requirements or the responsibility of the post-op care to another provider. And if there's no formal agreement, you would still, use this model and you would, the assuming provider on the other side to do the post-op visit would be allowed to bill this G0559 as an add-on code to the E&M service, the initial E&M service provided, to reflect the value of the additional work done in that initial visit. So the goal here is to say, let's get the valuation right by using these modifiers and getting this all corrected. But I still don't think that people are adopting this, so they still are not getting it fully corrected. And so there's a lot to be changed. So they're saying, let's take 3 different approaches, and you tell us what is the approach that you feel is most appropriate. And the approaches include this approach 1 and 3 are the physician time file based, where they take the physician time file that is included in the downloads within the fee schedule, and they say, okay, what are the work RVUs for approach 1, and what are the post-op work RVUs as a ratio against the total work RVUs. And then the approach 3 is the time-based component. So how much time is spent in post-op versus the total time. And they're getting 2 ratios there. So that's approach 1 and approach 3. But the model they would love for you to adopt is this second approach, and is the claims-based approach, where they have all of this data for the 99024, and they would take the median visit count and the median, kind of the average valuation of the visits, and say, okay, here is the valuation of this post-op portion of the service. So then it has taken this data and looked at it and said, okay, based on current values, we're getting about 79 to 81% for about half of the 90-day globals are relevant to the surgical component, and 90% for the 10-day global. But the 2023 data that they've accumulated for these 99024s say that effectively only 28% of that 90-day and the 2% of the 10-day are the relevant post-op visits that they valued within these services. So interestingly, they're focused on the increase to that surgical component as opposed to the decrease in that post-op component. But the average share would increase from 82 to 91% if they adopted this second approach. So if you were to say, okay, well, I'm going to delegate the post-op service, then you could do that and get a higher share of that surgical value for billing your code, and then the remaining services would be billed under the E&M codes and that G code. So there's kind of a upside potentially to this as well. So submit your comments regarding this. Do you think approach 2 is the best way to go, or do you think there's another way? There are codes that are in the list that don't even have percentages in them. Why do they not have percentages in them? And what is the appropriate percentage? And is it perhaps that the issue is that the 90-day global package is irrelevant to these codes? So we want to make sure that we're getting these correct. So moving on to skin substitutes. This is an important section because this is a significant change. But what I want you to hear is that this is not all skin substitutes. This is a certain categories of skin substitutes that are being valued less in the future. And they're trying to get the value to be more accurate, and you're going to see why. But I want to make sure we're on the same page regarding what skin substitutes are and how they're utilized. So skin substitutes are commonly used in outpatient setting. They're primarily used to treat diabetic foot ulcers and venous leg ulcers. The CPT or HCPCS codes that we utilize include reporting for the wound preparation, the product usage, and the application technique, whether we're suturing, etc. The CPT codes 15271 through 15278 describe the wound size and the anatomic location, and it's based on the application itself. So that is, we're applying this, so this covers the cost of the application itself. The additional codes, the supply codes, are in a separate list, and these would then be included. We're actually billing these supply codes in addition to these 1,500 codes, because even though in the past or in general we bundle the non-facility supplies, right? So we're usually saying, okay, here are the supplies that are bundled within each of these CPT codes. Historically, we've been permitted to bill for these wound care supplies under the ASP plus 6% payment methodology. So this is what is going to change. But I want to caveat this is that we also have an LCD that is proposed and is coming through right now and is kind of stalled out. Even though it was released in April 25, 2024, it stalled out because it got a lot of pushback. There's a lot of consternation around how this is going to be applied because of a lot of wound care products don't necessarily have to go through a high level of FDA criteria. And so if the LCD has a higher criteria than the FDA, then how does this pair up? And so look for this proposed LCD, understand it, learn how to apply it within your practice because it is coming. It is most likely to be adopted in some form, and these payments are likely to be adopted in some form. So we want to make sure we're ready by 2026 to be able to work through this. So keep looking out for that and keep advocating for yourself and products, et cetera, related to this. So what you'll see is that CMS is proposing a national standard payment methodology for certain skin substitutes. And it is doing this because it has seen the data over the last 5 years go from 250 million in spending to 10 billion in spending. So a 40-fold increase, whereas the number of patients that are being served is only doubled. And so this kind of disconnect is revealing a high cost of these skin substitutes, and they're trying to figure out how to mitigate this cost, mitigate this increase, and make sure that we're valuing these appropriately. And so they're considering taking a uniform rate this year. You'll see how they're valuing this in a minute, but they're taking kind of the weighted average of the different FDA categories that I'll show you in a minute at $125.38 per square centimeter. That is certainly a lower valuation than what you probably see on a regular basis, but there is kind of a difference depending on what service you're providing or what supply you're using. So it will be important to kind of look at that. But they're estimating savings of $9.4 billion if they make this change. So this is a big shift. The proposal in effect is that they're going to pay for skin substitutes as incident to supplies. You'll bill for the 1500 code along with the HCPCS supply code. The HCPCS supply codes are in the downloads of the fee schedule as well. The ASP reporting for the skin substitutes by the manufacturers will become voluntary because they'll no longer be paid under the 1847A provision. So they're bringing this under a different provision and then having that not be paid under ASP, but being paid based on a fee schedule. So the FDA groupings that they're utilizing are pre-market approved PMA, 510K cleared or de novo pathway devices, 361 HCTPs, and so they have these three categories, and the 510 and 361 are applications that are pretty much like a covering over a wound, as opposed to the PMAs that have a higher standard and higher requirement that kind of include treatment. They're kind of they actually resolve the problem. Usually they're working towards the treatment of the wound as opposed to just covering the wound and keeping the wound safe. So there is a difference, and they acknowledge a difference between the PMA services and supplies versus the 510 and 361. But they are carving out these Section 351 products that they're defining, hoping to define fully as biologicals, as they will still follow the ASP methodology. So again, if you have supplies that you're utilizing that are under this Section 351, there will be no change. But if you have these other supplies, then there will be a change in payment if adopted. So we want to make sure that, or CMS wanted to make sure that it was clear that the FDA considering something safe was distinct from CMS determining something was covered and reasonable and necessary. So CMS has the authority and dictates coverage over over a service. The FDA does not. So that is where this distinction and sometimes conflict occurs. So what can you do? I recommend assessing the product that you're utilizing currently. What are you using currently? What supplier contracts do you have currently? What is the FDA category associated with that product? And how is that going to be valued in the future? Is it going to be valued in such a way that you'll be financially harmed based on the contract you have currently with your supplier? Because many have supplier contracts that they are given the supply, they bill for the service, and then based on what is received, they pay the vendor back for the manufacturer for the supply. So make sure that you're not harmed in any way with that. And then adjust clinical protocols based on this as well. Review your charges to make sure they're applicable for lowered payment. Now, of course, you may have higher payment with your private payers, so you wouldn't want to lower it below what your private payers are still willing to pay. Make sure your staff, both your billing staff and your clinical staff, are educated around this, because the billing around these codes has been, significant departure from what we tended to have to think through because of the high dollar amount for some of these services. And then the documentation requirements under the LCD, adopting those now would be wise. But then, let your voice be heard. Make sure that CMS understands how this is impacting you. What is this going to look like for you financially? Are you going to be able to continue to provide these services, or are you not? What is your supplier saying to you regarding this? And note that the suppliers are also advocating for themselves to CMS and the FDA. So learn what they're doing and learn how this may play out for you in the future, because this is going to be somewhat volatile over the next few months and years. So I will stop there in regards to this and turn it over to Martie regarding care management. You're on mute.
I try to be quiet. There we go. It's a relatively quiet year on the fee schedule for care management services. We've been on this march now since 2013 of adding new Medicare coverage to address services furnished outside the four walls of the clinic or the four walls of the hospital. And so this year we have some clarifications, which do, of course, extend once again, the availability of care management services for our Medicare beneficiaries. Last year's big news, of course, was the creation of the Advanced Primary Care Management, or APCM, services. These were intended to pay practices that maintain the infrastructure to deliver care management services, rather than on a time basis of specifically providing services for a certain amount of time for a certain beneficiary. Instead, providing an opportunity for practices to bill for codes based on the composition of their Medicare panel, and again, their maintenance of those critical care management services. So as you recall, we have 3 codes under APCM. They vary based on the patient's condition. So for those individuals, Medicare beneficiaries in your practice with one or no chronic conditions, the opportunity to bill GO 556, the reimbursement there comes in at about $15 a month. GO 557 is available for those that have 2 or more chronic conditions. The reimbursement there is right at $50, so it's below the reimbursement for traditional 20-minute chronic care management services. And then finally, you have GO 558, which are for those individuals who have 2 or more chronic conditions and they are qualified Medicare beneficiaries. Again, the reimbursement here is significantly higher at about $108. So this is truly an opportunity, if you have those folks on your panel, to be generating revenue again by the maintenance of the infrastructure to deliver services to them. Key element here with all of the APCM codes is no time requirement. And as CMS has advised, if you are providing chronic care management services, you have the infrastructure, but in any given month, you don't reach the 20-minute threshold, this becomes the alternative to billing for the CCM services or the PCM services, depending on the specific beneficiary. Our goal here for in 2026 now is to figure out a way to add to that infrastructure the capacity for behavioral health integration. As it stands today, you can bill APCM and then separately bill one of the two behavioral health integration codes, either the Psychiatric Collaborative Care Model, or COCM, as it's generally referred to, or the General Behavioral Health Integration Code, or General BHI, as they're referred to. So unlike other codes that are exclusive, when you provide APCM, you can't bill separately for CCM, you can't bill separately for PCM, you can't bill separately for remote monitoring and the like. You can today separately bill for these codes. What CMS is proposing to do is this add-on code. So if you, again, have the capacity to deliver care management, but also maintain the capacity to provide these behavioral health integration services, we're going to allow an add-on code, so additional reimbursement now. Key here is the add-on codes don't have time requirements, and therefore it's broadening out your capacity to furnish these codes. Keep in mind, however, that if you are going to provide this in combination, you'll have your consent for APCM, but you will also need a separate consent that calls out the behavioral health integration services as well. So let's look at this in the context of the codes specifically. We'll start with 99492, which is the initial psychiatric collaborative care model code. That's 70 minutes of services furnished by the behavioral health care manager, but also having this capacity with a psychiatric consultant that care manager is consulting weekly regarding the patient panel with that psychiatrist, and they are advising on the appropriate management of those cases. So psychiatrists not directly involved in delivery of patient care, instead working through the behavioral health care manager, who then is partnering with the treating provider, who actually is the billing practitioner in these circumstances. There is then an add-on code that's provided, 99494, for additional 30 minutes above the 70. Then we have the 99493, which is provision of psychiatric collaborative care model in out months. So you have the initial month when the services are provided, and then subsequent months when they're provided. The requirement goes from 70 minutes to 60 minutes in these circumstances, and then the additional add-on code. In these instances for these codes, CMS is proposing the add-on code GPCM1 and GPCM2. Again, maintenance of the capacity, but not necessarily having to track the time for delivery of those services. Alternatively, the other model, I shall say, for delivering of behavioral health integration services is general BHI. In those instances, you don't have the involvement of the psychiatric consultant. It's simply the treating provider, the behavioral health care manager, that are working together to deliver these integrated behavioral health services. That currently is billed under 99484, which is at least 20 minutes of services furnished by the care manager. There is no add-on code for 99484. So what CMS is proposing here is an add-on code for APCM, GPCM3, and again, no specific time requirement associated with the delivery of these integrated behavioral health services. In terms of reimbursement, CMS is simply tracking the available reimbursement for the behavioral health integration services. So we're eliminating the time requirement, but we're paying the same amount as we would have paid had these codes been separately billed under APCM. So as there you see, this is the incentive that CMS is adding so that you expand that core infrastructure that you use for care management services to include this behavioral health integration. And again, consistent with ongoing Medicare focus on expansion of coverage for behavioral health services. And again, those services integrating into the delivery of primary care services, given research demonstrating the effectiveness of that particular model. So new opportunity there for practices, primary care practices, and other practices as well. It's not limited to primary care as a specialty, but to expand those capabilities and be able to draw down that additional reimbursement in support of those capabilities. Very briefly, Valerie had mentioned some unbundling of the communication technology-based services code in the RHC and FQHC setting. And CMS continues to propose this unbundling methodology. So you remember before last year, I guess in 2024 and before, when RHCs and FQHCs delivered care management services, regardless if that was chronic care management, transitional care management, principal care management, remote monitoring services, all of those were billed under a single code, GO511, with the same reimbursement for all of those services based on a national average. So beginning this year, for those codes, CMS unbundled GO511 and replaced it with directives to RHCs and FQHCs to actually bill the code and be reimbursed at the national amount for non-facilities services. Didn't say that very clearly, right? And so you're not getting a geographic adjustment. You're all going to get paid the same, whether you're an RHC located in Kansas or an RHC located in Tennessee. There will be no differences in the geographic payment. This year now, what they're proposing to do is do the same with GO512. And rather than having that separate code that RHCs and FQHCs bill, now the directive is for RHCs and FQHCs to bill the actual CPT codes. And again, that aligns with this movement towards APCM and the add-on code for APCM. And again, as Valerie mentioned previously, similarly, the last code to go, shall we say, for RHCs and FQHCs is G0071, and instead now you'll bill under those codes. G071 is, I think, reimbursing this year at around $13. G2010, G2250 bill in at about $12, so it's a little lower. The good news is 98016 is at about $15, so I guess there's some opportunity for increased reimbursement for our RHCs and FQHCs there. Switching gears, let's talk about changes to remote monitoring this year. And specifically CMS adoption of the recommendation to add codes for monitoring over a period of less than 16 days. So what CMS is proposing here is the creation of codes both under remote physiologic monitoring as well as under remote therapeutic monitoring, when the actual monitoring is from 2 to 15 days. So if you monitor patient only steps on the scale 10 days out of the month, before we couldn't bill for our RPM services, or at least the 99454 code, because we hadn't collected 16 days of data. So now we'll have a separate code that will reimburse for that lesser period of time of monitoring. Also, on the treatment management services that are furnished in conjunction with remote physiological monitoring and remote therapeutic monitoring, we will allow for reimbursement if only 10 minutes is spent delivering those services. However, critically important here, in that 10 minutes, it must include an interactive communication between the clinical staff and the individual receiving the monitoring services. That requirement still is maintained, even though the time period for billing these codes has now gone down to 10 minutes. Okay. Appreciate, very critically important here. If you deliver 15 minutes of time, you're still going to bill under the 10-minute code. You don't bump that up to the 20-minute code. These are specific time periods. You have to cross the threshold to bill for these specific services. The other critical change here, and it's subtle, but it's a very interesting change in policy by CMS, is how they're valuing or how they're proposing to value the data collection codes, which again, 99454 and the corresponding codes for our TM as well. These are practice expense only codes. There is no work RVU assigned to these codes because there's no physician work involved. It's just the practice expense associated with having the device transmitting, receiving that data, analyzing the data. That component is what we're focusing on here. Again, only practice expense and malpractice associated with those codes. What CMS is proposing going forward is to value those codes using data collected from hospitals under OPPS, because it believes those are more accurate reflections of the cost involved in delivering these services than the survey data on which RUC relies in assigning its values to those codes. So CMS has calculated out, using data from 2024, what the reimbursement then would be for these codes going forward, using that as the basis for calculating the practice expense. Again, the hospital data for calculating practice expense, which they believe is more accurate. In the case of RPM, you'll see the reimbursement go up. We got $3 additional reimbursement on 99454, but on RTM, you actually see the reimbursement going down slightly. So it's CMS seeks comment on this approach. It's very interesting to see if it's going to go. CMS has really never done anything like this to rely on hospital data with respect to those codes that are practice expense only. So we'll see if this is going to be an overhaul more generally. And again, if you were with us last week, Sarah Bowman discussed in detail CMS's concern about practice expense valuations, the CMS's reluctance. I think reluctance is actually too weak a word, sort of their resistance to rely on survey data going forward because they do not believe it's an accurate reflection of the costs involved. So this is a very specific example going forward of how they intend to change that.
And Martie, with the skin substitutes, they're doing the same thing. They're considering those cost reports as well and the volumes there. So it is interesting to see, I guess, because there's so many under this facility model now because of the employed provider groups that are out there, that there's a lot of data. So perhaps they're going to start shifting towards that.
Yeah, it's like it had been sort of the fee schedule, OPPS, and none shall pass between the two. And now we're seeing this kind of permeable membrane where data is being taken from one to inform the other. And yeah, just reflecting sort of the reality of practice now.
Yeah, exactly.
Okay, well, let's very briefly also what we've categorized within this care management, the services that have developed around social determinants of health. If you recall, back in 2024, CMS introduced reimbursement for SDOH risk assessments, community health integration, and principal illness navigation. The latter, CHI and PEN, as we refer to them, are services traditionally delivered by a community health worker as opposed to an MA or a nursing assistant or an RN. And it's measured by 60-minute increments of the services spent by those individuals working with patients to help them address those needs and to help improve their health outcomes, to help improve the physician's ability to diagnose and manage a condition. The change this year are twofold. First, wave goodbye to the term social determinants of health. This administration will not use the terminology SDOH. Instead, it replaces that terminology with upstream drivers, which actually is more inclusive and more descriptive, I believe, because you're going to start including behaviors like smoking, low physical activity, substance misuse, in addition to those environmental drivers like housing insecurity, housing instability, lack of security at home, those types of drivers. So we're going to marry this together into those upstream drivers of health, which again help improve that delivery of those CHI and PEN services. So that's good news. The one bad news here is that we're going to lose reimbursement for the risk assessment. So actually having individuals complete the risk assessment, CMS said, yeah, no, that's inclusive of other services, such as E&M services, such as community health integration, that simply count the time you would have, this is the message, I'm not sure they have this direct in describing it, but the time you would spend assessing a patient's needs as part of the community health integration services will be time counted there, as opposed to the separate reimbursement under GO 316. So I guess you effectively have from now till December 31st to get all those SDOH assessments completed to get the reimbursement in the door, assuming CMS is going to turn off that reimbursement starting on January 1st. We're going to wrap up here for a few minutes on prevention and wellness, which is, as you well know, a heavy-duty theme in the new administration under the Make America Healthy Again initiative. And we see that reflected in the fee schedule and really a precursor of things to come in 2027, 2028, and going forward. But let's start with the oldie but goodie, the Medicare Diabetes Prevention Program, or MDPP. Interesting program that actually was initiated by the YMCA under a CMS innovation grant back in 2012, 2013. And this is one where this Center for Medicare Innovation said, you're right, providing these services actually reduces total cost of care, improves health outcomes, so we need to pay for this. And so they created the MDPP. But it has literally taken them 8 years to finally get the reimbursement to a point that anyone's going to want to do this. So briefly, to remind you what MDPP is, it is eligibility for Medicare beneficiaries that are pre-diabetic. The definition of pre-diabetic, you see there the 4 bullet points that qualify an individual to participate in this program. These services are delivered by an MDPP supplier. That's a separate new category of Medicare provider. You can be enrolled as a physician practice, you can be enrolled as a skilled nursing facility, but you have to separately enroll as an MDPP provider to furnish and bill for these services. The key here is that you have to have CDC preliminary or full recognition as an MDPP provider. So CMS is saying, we're not going to mess with the qualifications of who is an MDPP provider or not. We're just going to rely on the CDC, their criteria, their recognition process. So you have to go through that process then to turn around, provide the services, and bill them to Medicare providers. This is a service that is a series of group sessions led by a lifestyle coach. The criteria to be a lifestyle coach, again, defined by the CDC, not by CMS. But individuals who enroll in this program do 16 weekly core sessions, followed then by 6 monthly follow-up sessions. And that's the realm of reimbursement. Now, what CMS is concerned about is no one's providing these services. Well, yeah, duh, because no one can figure out how to get reimbursed for it. I mean, I've stared at these charts and never been able to figure out exactly how this works. And not surprisingly, as of March 2025, we had only 331 enrolled suppliers. In the 8 years this program has been stood up, there's only been about 9,000 participants, kind of split equally between Medicare and Medicare Advantage. But at the same time, you've got AMA, American Medical Association, saying that we believe 50% of Medicare beneficiaries are pre-diabetic. In addition to 27% of Medicare beneficiaries already having diabetes. So these are not good numbers. I think I figured out the math was at current rate, CMS has reached about 0.0027% of potential Medicare beneficiaries that are pre-diabetic. So certainly we need to do something different if we want these services to be delivered. We saw some expansion of this program during COVID because we went from a wholly in-person program, meaning grandma has to get in the car and drive to her program every single week for 16 weeks to receive this program. During the pandemic, we decided let's go ahead and allow that to be delivered through what they refer to as distance learning in the CDC speak, or what we call virtual services. CMS has now decided to, has already expanded that to 2027. So we'll continue to allow distance learning. They also have permitted, as part of distance learning, you have to record weights as part of the MDPP program. And say they've allowed for individuals to weigh themselves, provided they take a photo of both the weight scale and showing that they're in their home at the time that they're delivering care. I'm not exactly sure how you do that, but that's been the rule going forward. They've also required during this period of time that MDPP providers have to certify that although they are delivering the services virtually, distance learning, they still maintain the capacity and the capability to deliver the service live, because CMS wants it to be beneficiary choice, whether they're going in person or they're receiving the care virtually. The big news was last year, last year in 2024, CMS said, okay, this payment structure is crazy. We're going to simplify it. We're going to provide straight up fee for service reimbursement for beneficiary attendance at a session. So if grandma makes it to a session 1, you're going to get paid for session 1. She makes it to session 3, you're going to get paid for session 3. It's not a combination of how often they attend. We're just going to pay on a per show up basis. And then they separately would provide performance-based payments tied to actual achievement of weight loss goals. And that's specifically focused around 5% of body weight loss there. But you see there the current reimbursement, it's $26 for each of these sessions they attend. And then you have those add-on payments associated with achievement and maintenance of weight loss goals. They've also added some clarification last year regarding incentives that an NDPP provider can offer to a beneficiary to participate in the program. And you see those specified here on the slides. Well, finally, drum roll, please. Here are the proposed changes. They first say, let's continue the virtual option through 2029, which is great. So that distance learning, that combination of in-person and distance learning or straight distance learning, we're going to continue that going forward. And great news here, discontinue the requirement that a supplier has to demonstrate the capability and capacity to deliver the services in person. So you can have a truly distance learning MDPP provider now. You don't have to have a warehouse address where you get together, turn on the heater and do MDPP training. But most importantly, adding the asynchronous delivery modality, what they refer to as online sessions. They are going to allow this through 2029. They refer to it as a test to see if it is as effective in delivering the services. If you are a current MDPP provider, you are going to have to go through CDC and get a new registration number as a deliverer of online services. And again, don't confuse distance learning with online. Online is referring to that asynchronous, I'm going to call up the web page and work my way through the content. Okay, so they're very, very different. The program is going to have to adhere to the CDC standards for delivery of these online asynchronous services. And critically important here is that an individual who is working their way through this asynchronous program has to have the opportunity to engage with a live coach, not an AI tool, a live human being associated with each session. So a prompt saying, hey, if you want to call in, talk to a coach, here's your opportunity to do so. And that, in fact, there needs to be that interaction between the coach and the beneficiary on a regular basis. CMS does note that texts and emails qualify so long as they're bi-directional. So you can't just send out recipes and call that good by text. You actually have to have a back and forth with the beneficiary to qualify. The answer here is you have a new G code. It's going to reimburse at $18 a session as opposed to the $26 per session for the alternative. Keep in mind here, you can't mix the two. You can't have partially synchronous and partially asynchronous. So if the person is doing the asynchronous program, they do it straight through. You can't have switching back and forth and doing a live group session one day and an asynchronous the other day. They also have expanded out the opportunities with regard to photos for the services. You see those detailed there. Digital mental health treatment, again, Valerie referred to this previously, creating new reimbursement for services of 2025, focused on a particular type of DMHT services. They're proposing in 2026 to expand that out to a new category of services specifically for the treatment of ADHD. Everything else would remain the same with regard to that reimbursement. There is a solicitation included in the proposed rule regarding digital health reimbursement. That's broader than just using digital tools for mental health services. They're asking here, how do we create reimbursement for using these digital tools in different scenarios, such as encouraging healthy lifestyles, for example, or otherwise using this technology in part to diagnose autism potentially. So opportunity for comment there in the rule. Also in the proposed rules, a comment solicitation on software as a service and artificial intelligence, how CMS should develop its payment policy. As I said, here's the long-term component of the proposed rule this year. You see on the screen here the specific topics on which they are seeking comments to help CMS develop its reimbursement policy. And finally, a very important request for information included in this year's proposed rule, focus on prevention and management of chronic diseases. How should CMS expand out reimbursement policy to encourage engagement by providers in the day-to-day lives of their patients to help them improve their healthy lifestyles? And again, what options are available to CMS and how should we prioritize them? Again, you see here on the screen sort of the realm of the possible that's identified by CMS in the proposed rule. Please, if you have interest in any of these topics, we encourage you as strongly as possible to provide comments to CMS and to provide direction on these different concepts and how reimbursement can move forward. It is now speak now or forever hold your peace. Well, not forever hold your peace, but this is the opportunity they're giving us to comment on current reimbursement, how it can be improved, as well as future reimbursement. So we have given you our walk through the proposed Medicare physician fee schedule rule. In these two webinars, our next healthcare regulatory roundup is scheduled for August 27th, and there we will dive into the final inpatient rule that was released earlier this month and all the details there. So on that note, I'm going to turn this back over to Jennifer to take us home.
Wonderful. Thanks to our presenters, Martie and Valerie. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Thoughts Leadership section of PYA's website, pyapc.com. While at our website, you may register with other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.